morning, everyone. Okay. Hopefully that I can keep you awake at the beginning of the morning. So thank you for the committee for having me today. It's my pleasure to present my topic, and the topic is to discuss about the isolated ocular motor palsy. Should be imaged or not? And my answer is yes. Isolated ocular motor palsy is referred as the group of isolated cranial nerve palsy, the third, fourth, and the sixth, that can result from demyelination, compressive lesion, or ischemia. Neurologically, it's usually assumed that an acute Pandy's palsy can spontaneously result within 3 months under observation and without any treatment, since the most common cause is microvascular ischemia. However, it should only be considered as an exclusive diagnosis, and regarding the management, we cannot confirm microvascular ischemia without having a neuroimaging study to guard against missing other life-threatening conditions. In fact, isolated ocular motor palsy are not uncommon presentation to the neuro-ophthalmologist and also frequently present to the non-neuro-ophthalmologist. Although a patient over 50 years old coming to see you at the clinic with ptosis or diplopia suddenly noticed along with the vasculopathic risk factors, it does not mean that there is nothing but microvascular ischemia. And if we are not experienced in taking the medical history, or if we do not have time to fully examine the patient's eye, we are at high risk of misdiagnosing, and the decision of ordering a neuroimaging or not is yours. And to fuel the debate, we can go through the use of conditions, the necessity of the neuroimaging in case of the third nerve palsy, and then the fourth and the sixth nerve palsy. Despite the fact that the management cost has to be controlled, this clinical condition should be considered in a different way. One study calculates the chance of detecting a serious cause other than microvascular ischemia in case of the fourth and the sixth nerve palsy is 1 in 20 cases, and much higher if we also include the third nerve palsy. Indeed, Shu et al. Looked at 66 consecutive patients diagnosed with isolated ocular motor palsy to determine the role of neuroimaging in the diagnosis, and the cumulative incidence of finding identifiable lesions was up to 14%. Moreover, we have to acknowledge that the access to the neuroimaging study is now much improved, as almost every single hospital, especially in the Ho Chi Minh City and the surrounding areas, has suitable facilities. Besides the new treatment and the positive outcome, in case if we can early diagnose the harmful but treatable lesions such as strokes, brain tumors, or deadly aneurysm, also support my recommendation for routinely ordering a neuroimaging in the management protocol of these clinical conditions. Regarding the third nerve palsy, there is now a uniform agreement that all cases of the third nerve palsy should be imaged by reason of the significant frequency of the deadly aneurysm. More recent data suggests that extremely relying on the clinical side of symptoms can lead to a misdiagnosis. For example, the pupillary dilation indicating a compressive third nerve palsy rather than a microvascular ischemic third nerve palsy. Indeed, there's a study recently published in 2017 on JAMA Ophthalmology by a research group from Mayo Clinic using the population-based method to determine the incidence and etiologies of the isolated third nerve palsy over 30 years from 1978 to 2014 in Minnesota, United States. And the report showed that there's only 60% of the microvascular ischemic third nerve palsy have the involvement of the people. And on the other hand, there's only 64% of the compressive third nerve palsy presenting with the pupillary dilation during the clinical course. More interestingly, if we only count the compressive first nerve palsy from the intracranial aneurysm, there's only 33% of the case having the pupillary dilation from the beginning of the clinical course. Therefore, the lack of pupillary dilation in the clinical course of the isolated first nerve palsy is only a recommended sign indicating a microvascular ischemic first nerve palsy, but not a fully reliable sign to rule out a compressive first nerve palsy. Another fascinating finding is related to the clinical course. The typical clinical course of the isolated first nerve palsy is described as follows. First is the first nerve palsy without any other sign or symptoms except headache and periorbital pain. The second is the first nerve palsy having the spontaneous recovery or substantial improvement within 3 months under observation and without any sign of aberrant regeneration or other neurologic symptoms. The report showed that 95% of the microvascular ischemic first nerve palsy present with this typical clinical course. However, we have to be careful since 67% of the first nerve palsy from the compressive first nerve palsy from the intracranial aneurysm also follow this typical clinical course. And if we count all together the compressive lesion, the incidence was 36%. So neuroimaging in the isolated first nerve palsy is highly recommended. In case of the fourth and the sixth nerve palsy, based on multiple data, most of the cases are due to the microvascular ischemia. In 2017, Ivan et al. Suggests that the profile examination can help to distinguish the congenital and ischemic from the tuberous fourth nerve palsy. Nonetheless, the skill set needed to detect the clinical pattern in those clinical situations is not familiar to all the ophthalmologists, especially for the non-neuro ophthalmologists. So we are at high risk of missing the potential harmful but treatable lesions. In 2017, Hanker et al. Urged that brain MRI should be considered as the initial evaluation for all the older patients having the isolated oculomotor palsy, whether or not the patient present with the vasculopathic risk factors. Other study from Prina in 2007 and Peters in 2002 additionally proposed that neuroimaging is particularly important in the younger adult in respect to the high risk of neoplasm in this age group. There's also the case report from World War in 2006 about the case of isolated sixth nerve palsy associated with the deadly pituitary apoplexy. Theoretically, the cavalocylus disease can initiate with the isolated cranial nerve palsy, and the sixth is the most common. Adding to the argument, OPFO presented the spontaneous recovery or substantial improvement of the isolated sixth nerve palsy case on the patient having a significant skull-based disease, a skull-based tumor. Once again, neuroimaging is proving its significant importance. In the real clinical practice in Vietnam, we still do not have a strong electronic medical record system, and the strong connection between the medical clinics making it really difficult to assess the patient history in relation to the previous management. So that a neuroimaging study in your hand can become a substantial data for your clinical diagnosis. Altogether, neuroimaging in case of the isolated oculomotor palsy should be acknowledged in a high priority list of evaluation to rule out the harmful or deadly lesion, but treatable one, and to clearly prove that it's a truly isolated case. It can come from the microvascular ischemia. Thank you for your attention.
Okay, right. So Can I? Yes.